วันที่2ค่ะดิฉันศรีสุดางามขำนะคะพยาบาลวิชาชีพค่ะ
สวัสดีครับผมอาจารย์ดร.ลิขิต เปรียนนท์อาจารย์จากคณะเทคนิคการแพทย์มหาวิทยาลัยมหิดลครับ
ค่ะจากการอบรมไป1วันนะคะเป็นอย่างไรบ้างคะสำหรับการประชุมเมื่อวานนี้ที่ผ่านไปในเซกชันเช้าเรามีอะไรกันนะคะตอนเช้า
เมื่อวานนี้เรามีปาฐกถาทั้งหมด3เรื่องนะครับจากท่านศาสตราจารย์นายแพทย์วิจารณ์พานิชนะครับแล้วก็จากท่านศาสตราจารย์คลินิกเกียรติคุณนายแพทย์เปียสกลสัตยาธรนะครับและนายแพทย์โสพลเมฆทนปลัดกระทรวงสาธารณสุขครับซึ่งเมื่อวานเราก็มีการทั้ง3ท่านก็ได้พูดคุยไปในทิศทางเดียวกันนะครับในเรื่องของการเปลี่ยนแปลงของสังคมนะครับที่มีการเปลี่ยนแปลงอย่างรวดเร็วนะครับซึ่งระบบสุขภาพก็ต้องมีการปรับตัวตามไปด้วยนะครับซึ่งก็สอดคล้องกับการผลิตนะครับกำลังคนทางสุขภาพนะครับซึ่งก็จะโยงมาที่การศึกษาของทางสุขภาพโดยตรงนะครับ
อาจารย์ก็จะเน้นในเรื่องของ 21st century skill นะคะเพราะนั้นนักศึกษาในอนาคตของเราก็คงจะต้องกล้าคิดใช่ไหมคะเป็นคนดีเก่งกล้าแล้วก็กล้าคิดกล้าทำนะคะสุดท้ายเองก็ต้องมีความสุขใช่ไหมคะเพราะว่าท่านรัฐมนตรีเองก็เน้นในเรื่องของความสุขในบุคลากรแล้วก็ well-being ของประชาชนทั่วประเทศนะคะ
แล้วก็รวมทั้งการทำงานเป็นทีมนะครับทีมของสุขภาพที่จะลงไปดูแลคนในทุกๆระดับนะครับเพราะฉะนั้นคนที่จบทางด้านสุขภาพก็ต้องมีความสามารถในการที่จะสื่อสารนะครับแล้วก็ทำงานกับผู้อื่นได้เป็นอย่างดีนะครับ
ใช่
ซึ่งเมื่อวานเองพอช่วงบ่ายเราก็จะมีเป็นห้องย่อยๆนะครับซึ่งก็จะมีการพูดคุยกันในแต่ละประเด็นในเรื่องต่างๆอย่างเช่นการปฏิรูปการศึกษานะครับแล้วก็เรื่องของ
ความร่วมมือนะคะความร่วมมือในการจัดการเรียนการสอนนะคะระหว่างฝ่ายศึกษากับฝ่ายบริการนะคะตลอดจนก็มีผู้เข้าร่วมนะคะเสนอว่าเราเองก็ต้องคำนึงถึงชุมชนมากขึ้นนะคะรวมทั้งผู้นำของชุมชนปราชญ์ชาวบ้านนะคะที่จะต้องเข้ามาเป็นอาจารย์ของนักศึกษาของพวกเราในอนาคตนะคะแล้วก็มีบางห้องแต่แล้วเราไม่ได้เข้าร่วมนะคะไม่ทราบว่าแต่ละท่านมีข้อคิดหรือข้อเสนอแนะอะไรไหมคะจากการที่เราเข้าร่วมฟังเมื่อวานนี้ตอนบ่ายเพราะว่าบางพิธีกรทั้ง2ท่านก็จะเข้า attend ในบางห้องเท่านั้นเอง
จริงห้องที่ผมเข้าก็ค่อนข้างแน่นนะครับแอร์ค่อนข้างจะร้อนเลยทีเดียวเพราะว่าคือเรากั้นห้องนะครับห้องนี้เรากั้นเป็น2ห้องนะฮะแล้วก็ห้องที่ผมอยู่คือห้อง ID Form ของอาจารย์พงศักดิ์เนี่ยก็ค่อนข้างแน่นนะครับแต่ไม่ทราบว่าห้องอื่นๆนี้เป็นยังไงบ้างนะฮะตอนนี้เราเปิดฟลอร์นะครับทุกท่านสามารถที่จะแสดงความเห็นได้นะครับเพิ่มเติมให้กับท่านอาจารย์ที่เป็นผู้ดำเนินรายการในเมื่อวานนี้ได้เพื่อจะไปปรับปรุงหรือว่าไปเพิ่มเติมได้นะครับเพราะเรายังพอมีเวลานะครับช่วงเช้า
มีห้องอาจารย์อนุภาพอาจารย์ก็ได้ข่าวว่าอาจารย์ก็คนเยอะใช่ไหมคะมีใครได้เข้า attend ห้องอาจารย์อนุภาพบ้างไหมคะอาจจะยังอะไรนะคะอาจจะตุ๊กว่าอะไรนะคะกลัวโดนถามคำถามแต่วันนี้เรามีอะไรนะคะสิ่งที่น่าสนใจนะคะก็คือในภาคบ่ายนะคะแต่ละท่านนะคะฟังบรรยายในเช้านี้ดีๆนะคะแล้วก็เสร็จแล้วบูธข้างนอกของเรานะคะโดยเฉพาะของราศีสไลด์นะคะของมหาวิทยาลัยมหาสารคามนะคะแล้วก็มีบูธของ One Health นะคะที่ในภาคบ่ายเราจะมีentertainment นะคะที่อาจารย์ตุ๊กนะคะซึ่งเป็นผู้ดำเนินรายการในภาคบ่ายจะมีคำถามนะคะแล้วก็ให้แต่ละท่านได้ลองเข้า Access นะคะโดยใช้สมาร์ทโฟนของแต่ละท่านแล้วก็เล่นเกมร่วมกันผู้ชนะเลิศจะได้รางวัลเป็นอะไรนะคะอาจารย์
รางวัลเป็นโทรศัพท์มือถืออะไรสัก77สักอย่างนะครับอาจารย์ลงท้ายว่า77นะครับผมจำได้ว่า7แน่นอนนะครับแต่ไม่แน่ใจว่าข้างหน้านี่อะไร
เราข้ามโน้ต5ไปแล้วใช่ไหมเราข้ามโน้ต5นะคะเราข้ามโน้ต5ไปแล้วตอนนี้เราเป็นเวอร์ชัน7นะคะแล้วก็เราข้าม Thailand 4.0 เพราะนั้นเราใช้สมาร์ทรุ่น7นะคะแต่ว่ายังไม่แน่ใจว่าอันไหนนะคะ
อันนี้เราแจกในเซสชันเลยนะครับเราแจกในเซสชันเลยแล้วก็เมื่อวานไม่ทราบว่าพิธีกรได้ เตือนเรื่องของมือถือหรือยังเพราะว่าอันนี้มือถือใครถ้าความไวอินเทอร์เน็ตเร็วอันนี้ได้เปรียบนะครับได้เปรียบเพราะเราจะแข่งขันกันนะครับแข่งขันกันเพราะถ้ามีมือถือที่ไวตอบได้เร็วก็สามารถที่ก็มีโอกาสได้ชิงรางวัล
คำตอบถูกต้องใช่ไหมคะ
เราไม่ได้สุ่มนะครับเราไม่ได้สุ่มเลือกใช่คำตอบถูกต้องตอบได้เร็วนะครับจะมีโอกาสได้รางวัลนะครับรู้สึกจะมี2รางวัลนะครับ
2 รางวัล
รางวัลเดียวรางวัลเดียว
เหรอคะโอ้โห the best เลยใช่ไหมคะเนี่ยนะคะต้องถูกต้องและเร็วที่สุดเท่านั้นที่จะได้รางวัล1 รางวัลนะคะสำหรับภาคบ่ายนะคะ
แต่เราก็ยังมีชิงรางวัลแบบสอบถามนะครับสำหรับท่านที่ไม่ได้มาเมื่อวานนะครับกรุณาช่วยตอบแบบสอบถามแล้วก็ส่งคืนให้กับทางเจ้าหน้าที่นะครับเราจะมีตัวเลขนะครับเลขที่แบบสอบถามเพื่อจะไว้ชิงรางวัลอันนั้นก็เป็นอีกอันนึงนะครับว่าเรามีรางวัลทั้งหมด2 ส่วนในการนะครับ
วันนี้ก็จะมีแบบประเมินนะคะวางไว้ที่นั่งอยู่แล้วนะคะถ้าท่านได้ฟังบรรยายเรียบร้อยแล้วนะคะกรุณาช่วยตอบแบบประเมินด้วยนะคะอันนี้ก็เป็นส่วนหนึ่งที่เราจะมอบรางวัลให้นะคะแล้วก็มีการมอบหนังสือเห็นอาจารย์หมอวิมบอกว่าหนังสือในการประชุมครั้งนี้เรามีถึง7 เล่มด้วยกันนะคะหลากหลายเล่มนะคะที่เราสามารถจะเก็บไปเป็นความรู้และนำไปใช้ประโยชน์ได้นะคะทีนี้สำหรับวันนี้เรามีอะไรบ้างนะคะตารางที่เราจะบรรยาย
ช่วงเช้านะครับจะเป็นplenary talk นะครับจากดร. จอห์น กิลเบิร์ตนะครับเรื่องของ concept of interprofessional education นะครับต่อจากนั้น
ก็พักรับประทานอาหารว่างนะคะช่วงสัก15 นาทีแล้วก็10 โมง 15 ถึงเที่ยงนะคะจะเป็นพาเนลร่วมคิดร่วมทำ IPE Thailand 4.0 นะคะก็ใช้เวลา2 ชั่วโมงจนถึงเที่ยงนะคะแล้วก็พักรับประทานอาหารกลางวันภาคบ่ายนะคะ
ภาคบ่ายนะครับจะเป็นการนำเสนอนะครับและอภิปรายเรื่องเดินหน้าร่วมขบวนเดินช้าตกขบวนนะครับเป็นหัวข้อที่น่าสนใจทีเดียวนะครับและอันนี้แหละครับที่เป็นหัวข้อที่เราจะมีการเล่นเกมชิงรางวัลกันด้วยเพราะฉะนั้นช่วงพักเที่ยงนะครับหรือว่าช่วงระหว่างนี้ถ้ามีเวลาก็ไปเดินชมบูธด้านนอกเพราะว่าคำถามส่วนหนึ่งจะมาจากบูธที่อยู่ด้านนอกนะครับ
เมื่อวานนี้ในห้องของอาจารย์หมอพิเศษนะคะก็จะมีผู้เข้ารับการอบรมหลายท่านนะคะกำลังสนใจแล้วก็มีข้อสงสัยมากมายว่า IPE มันเป็นอย่างไรและที่เรากำลังทำกันอยู่การจัดการเรียนการสอนอยู่ตอนนี้มันใช่ IPE หรือยังแล้วเราจะทำได้อย่างไรนะคะในเซกชันบ่ายของเราเนี่ยแหละค่ะเราจะมีตัวอย่างนะคะแล้วก็การจัดการเรียนการสอนที่เราได้ร่วมนะคะคณะทีมงานผู้ดำเนินการอบรมในเรื่องของ IPE นะคะร่วมกันคิดร่วมกันทำหนังสือคู่มือมา1 เล่มนะคะอันนี้เราก็จะเป็นประโยชน์นะคะแล้วก็เดี๋ยวจะมีการแนะนำในภาคบ่ายหลังจากนั้นก็
เป็นบรรยายเรื่องแผนงานในอนาคตนะครับและต่อด้วยwrap up และ closing session นะครับในเวลา 15 นาฬิกาถึง 16 นาฬิกาครับ
ค่ะอันนี้ก็จะเป็นตารางในการอบรมของเราในวันนี้นะคะเลิก 4 โมงเย็นจากนี้เราก็จะขอเดี๋ยวแต่ละท่านนะคะอันนี้นะคะที่เป็นหนังสือนะคะการศึกษาแบบสหสาขาวิชาชีพหรือว่า interprofessional education นะคะที่คณะทีมงานของเรานะคะมีทั้งหมดอยู่กี่ท่านในกันนะคะเนี่ยอันนี้นะคะอันนี้ทีมงานนะคะที่แต่ละท่านจะได้รับการแจกหนังสือเล่มนี้เพิ่มเติมนะคะเดี๋ยวจะมีทีมงานของเราเดินแจกผู้เข้าอบรมแต่ละท่านนะคะ
ทีมงานแจ้งว่าจะแจกในช่วงบ่ายนะครับหนังสือเล่มนี้แจกในช่วงบ่าย
ใช่ไหมคะนะคะอันนี้ก็เป็นอีก1 เล่มนะคะที่น่าสนใจแล้วก็แต่ละท่านสามารถนำไปใช้ในการจัดการเรียนการสอนแบบ IPE ได้นะคะแล้วก็ถ้ามีข้อสงสัยในเซกชันบ่ายนะคะเราก็จะสามารถdiscuss เปิดประเด็นนะคะศึกษาในเรื่องของการจัดการเรียนการสอนแบบ interprofessional education ได้นะคะค่ะอันนี้ก็ได้เวลานะคะเริ่มเซกชันแรกนะคะ
ครับผมจะขอแนะนำท่านวิทยากรของเซสชันแรกนะครับ The first plenary talk today is given by Dr. Professor John Gilbert titled Concept of Interprofessional Education. Dr. John H.V. Gilbert has been a seminal leader in the education of health professionals in British Columbia, Canada, and internationally. He received a highest order of Canada Model, which is for an outstanding contribution at the local and regional level in Canada. Currently, Dr. John Gilbert is Professor Emeritus at the University of British Columbia, an adjunct professor at Dalhousie University. He's serving as Dr. TMA PAI Endowment Chair in Interprofessional Education and Practice at Manipal University. He's also an adjunct professor at University of Technology, Sydney, Australia. He's also a senior scholar at WHO Collaborating Center on Health, Workforce Planning and Research at Dalhousie University, and also a founding chair of the Canadian Interprofessional Health Collaboration. So please welcome Dr. John Gilbert to the stage.
Arun Sawas. Good morning. Bonjour. It's a wonderful pleasure to be back in Bangkok and in Thailand. I have many good memories of being here on previous occasions. I think the traffic has gotten worse, however. It would not be appropriate of me to pass this possible moment to thank the organizers of this meeting for inviting me to talk with you today, and also to the very hardworking people who are out there making sure that you are registered, who did everything that they possibly could to ensure that my trip to Bangkok and my stay is perfect. So I thank them. Interprofessional education for collaborative, patient-centered practice is a very complicated and complex topic. So this morning what I want to do is talk about interprofessional teamwork, because at the end of the day, what interprofessional education aims for is teamwork that is informed and informing about the patient or subject or whatever it is you call them today, client, so that the quality of care is significantly improved. The quality of care is what interprofessional education for collaborative patient-centered practice is about. So I'm going to walk you through a number of issues which have, I don't know, kind of confused me over the years. But first I want to tell you about my country. This is a map of Canada. It's a big place. It's 445 miles from that coast to here where it says St. John's, Newfoundland. 4,500 miles. When I was young and very foolish, I'm simply foolish now, I drove from Vancouver to St. John's, Newfoundland in a Triumph TR6 and back by myself. And I discovered that Canada is a very big country. And of course, south of Canada is another place which I will not talk about today. So what am I going to try to do with you? I have this narrative. I'd like to talk about some fundamental issues for IPE and IPC, which is interprofessional care. I'm going to ask the question, IP teamwork, it matters. We had an interesting conversation yesterday afternoon in this room about that very issue. criteria. What are the criteria that we consider for interprofessional teamwork? What are the barriers? How do we evaluate it? And what's the road ahead? It's very exciting to be in a country where there is this enthusiasm for moving interprofessional education for patient-centered collaborative practice in the ways in which I was listening to yesterday afternoon. These are silos. You have them in your country, and we certainly have them in ours. In our country, we bring in grain from the Great Plains of Canada, and we store it in these silos. Our educational system is a bunch of silos. Medicine, nursing, etc. But not only the education system, the healthcare system is very heavily siloed. And people live in that silo as though there were no other silos. It's a very difficult problem to get our colleagues to move out of the silos they are in, to understand what is in the other silos and what opportunities they present for addressing the education and practice of health professionals. It's also a tale of many interpretations, and I understand there are many elephants in Thailand. In fact, I rode on one in Chiang Mai a number of years ago. But I hope you can just do the translation of the simple English words. So if you ask one health professional what it is they feel in healthcare, they'll say, it seems that it's a rope. You ask another health professional and they'll say, it seems like a wall. You ask another one and they say, it's a fan. Health and social care professions have all of these stories about what health and social care is to them because they have been trained, educated that way. And this is an enormous problem in the same way as the silos are an enormous problem. So let's look at this word interprofessional. And what I want you to notice is that there is no hyphen in interprofessional. No hyphen, because when Microsoft Word wanted to put it in, I took it out. Because we have a very clear understanding of what interprofessional means when we are talking about health and social care. And that meaning is compressed into one word, interprofessional. And let me be clear, because yesterday I was telling the lead for the afternoon, I wanted to jump in and say a few things. Let's be clear that I am not talking only about regulated health professions. I am not talking about only regulated health professionals. In this context, interprofessional means anybody who is involved in the education and the care of the patient. Sometimes that means the person who's in cleaning the room, the ward. Sometimes it means the clerk on the front desk. They are as important members of our interprofessional team as the surgeon. I was in hospital once for a relatively minor event. Gives you a good experience so you can say, well, I was a patient. And I was in the room for 2 days. And on day 2, a man came in with his broom and his bucket. And he said, Dr. Gilbert, I want you to know that I am the most important member of your team. I said, oh, Why is that? He said, because I am preventing you getting MRSA. So interprofessional is not just regulated, okay? We have to think across that very broad continuum of those who are involved in the care of the patients. So let's get the right word, interprofessional, and let's get the word right, please. There are three parts to now what is a kind of universally agreed on definition, which comes from the United Kingdom, from the Center for the Advancement of Interprofessional Education, about 20 years ago. Learning with, from, and about. Learning with, from, and about. Three very, very important words. For the purpose of collaboration, you want to learn with, from, and about so that you can indeed collaborate more efficiently, more effectively, and more sensibly. Second part of the definition. Why? Because, as I said earlier, we want to improve the quality of care. And each of these parts of the definition are now being tested in some fashion. The one that we are not really very far ahead of at the present time is quality. And we talked about quality yesterday in a number of different ways. But quality is very hard. And it's even harder when, as yet, we're not sure about with, from, and about, and what is real collaboration, okay? But we're getting there. We're getting there. And the work that you're doing and will be doing will help us get even further. So get the right word, get the word right. It is not just one thing. It is three things, and they are testable. Now, why does it matter? Well, some of you will recall that way back in the early 2000s, a very famous report was published by the Institute of Medicine in the United States, which is now the College of Medicine, I believe, in the United States, said, "To err is human." And what that study showed was that in the United States every year, approximately 85,000 people died unnecessarily because of errors in the system. Not necessarily medical errors, okay? Let's get that clear. Errors in the system. Despite the 15 years or so which has passed since the publication of that report, the number of errors has increased. And we have the same problem in Canada. We had a whole study done on adverse events, because that's what we call them, not errors, adverse events. Same numbers. So why do we want to do it? Well, we want to do it because we want to improve the quality of care. We don't want that number of people to die unnecessarily. Every human life is a value. We want to enhance patient safety. And all of you will know that the place where we learned most first about safety was the airline industry. The big crash, I can't remember which plane it was, back in the late 70s, alerted the airline industry to safety. It took the health field a long time to catch up with that notion. Checklists are still a problem, okay? But what we want to do through interprofessional education teamwork is to enhance patient safety. And one of my honors at the present time is I sit in British Columbia on the Patient Safety and Quality Board. We deal with many, many issues around safety as it pertains to quality. So quality and safety go together. And then we want to reduce the workload issues that cause burnout among healthcare professionals. And because so many healthcare professionals, health and social care, because I want to include social work, counseling in this, because so many of them work in parallel, there's a lot of reduplication of the things that are done. How many times do you as a patient need somebody to take your case history And how many times can you count on your hand the number of times that your case history has been taken when you visited acute care? So why? It matters because we know that interprofessional teamwork is more responsive and it's more patient-centered. When a team comes together to figure out what to do, the responses change around the care of the patient, and the focus becomes much more centered on the patient as a patient and not the patient as a collection of body parts or diseases. So, we know it's more responsive. We know it's more clinically and more cost-effective. There's lots of data now that tells us when you have really good teamwork, the costs are reduced significantly. And as I said, when I talked about the case history, it definitely avoids duplication. And in avoiding duplication, it avoids fragmentation. Because when you have a group of health social care providers working independently, you get a lot of fragmentation in care. Teamwork pulls that together. And when you have to think about the teams within the healthcare context, you begin to think about organizational planning. The team as the deliverer of care. The team, not the individual health professional. Of course, there are individual health professionals associated with team. You begin to think of which team is going to handle this, which team is going to handle that, etc. And we know that it improves admission, it improves handoff and transfer of care, and it improves discharge planning. And let me tell you that the three big areas that we can do a lot of work in around interprofessional education are discharge planning, rounding, shift change. Discharge planning, rounding, and shift change. If you want to look at where lots of errors occur in the care of the patient, look in those three places. Okay, so why? So let's just think about then the scope. Well, the first criteria is that many disciplines within the team cover a diversity of distinct knowledge and the skills that are needed for patient care. I mean, a team is not everybody thinking about just one thing. Of course you had to have the physician and the nurse and the pharmacist and the social worker and the occupational therapist, etc. You need those distinct professions to bring their light to bear on whatever the problem is the patient's presenting with. And because of that, the plan of care that is produced by that diversity of disciplines coming together reflects the integrated set of those considerations. It's not, oh, this is what X does, this is what Y does, this is what W does, this is what A does. It's this is what we do for the patient. Okay? And we're not very good at this yet. Team members share information and coordinate services. It's still not clear to me yet in the data what it is in terms of information that is shared that is truly applicable within a clinical setting. Let me give you an example. Much information that is exchanged is numerical. It's stuff you can add, multiply, divide, etc. It's the quantitative stuff. You know, that's easy. You can put it on the chart, and X can look at it, Y can look at it. The tough stuff is the stuff that's about the family, you know, the patient, the environment in which that person is embedded before they come to you and then when they go back. That is what you need to share in the team. What do they know about that cultural surround that ultimately is about more than let's get the meds right? Although that's very, very important, don't misunderstand me. You have to know whether there's a support system. So I don't know yet about Thailand and hips, knees, shoulders. We have a big factory at my university, the shoulder, hip, knee factory that does a zillion of these operations every year. 33% of the patients receiving one or other of those surgeries is back in the hospital after 3 months. And you know how expensive that is, right? Back into Emerge, and the Emerge costs are like this. Why? Because the cultural surround of that patient was not understood in the team before the patient was operated on. Consequently, the question about what's the after-surgery care going to look like is not seen, not understood, not even asked about. It is now, because we're working on that. So very, very important that the team members share not just the quantitative information that they've measured, but also what they know qualitatively about the culture. And that is very, very, very interprofessional. Yesterday, again, it was a very interesting conversation. And as I said, I was itching to jump up and say, oh, I don't think you should do that. Let me tell you why. Classroom learning is not workplace learning. Classroom learning is not workplace learning. You know, we can sit students in a classroom and bore them to tears with all the stories that we have about patients. It's not until you take a student to a patient, client, customer, whatever you call them, in the place where that person is being treated, that the lights go on and they say, oh, that's why I'm going to be a doc. That's why I'm going to be a nurse, okay? So classroom learning is good for certain things, but it doesn't teach you about the patient in situ, okay? Teamwork, however, has to be taught and it has to be learned. It's not some miracle that just happens. And there's a lot of confusion about this. People seem to think that it comes by osmosis, you know? People will just learn to be nice to each other and play in the same sandpit, etc. No. There are principles to teamwork. We've learned a huge number of those principles from business. Big car companies, Toyota, remember Lean, Sigma 6, remember GM. We've learned a lot about it. So we need to bring that, and that can be done in the classroom. The abstract concepts can be done in the classroom, but it has to be taught, and then you transfer it to a place where it has been learned. And one of the great opportunities for us in health education, health services now, is the mannequin, you know? Being an absolute gem for learning on. So teach it and learn it. It's not a miracle. And it has to be built every day with every patient, with every care provider, professional, and family, because family are care providers, and we forget that frequently. And we're trying to do in Canada an estimate of, you know, the billions of dollars that are given to the care of patients by their families. And we just don't have a number, but it is huge. So it has to be taught, must be built strategically with those people as well. You can't ignore them. Every day, every patient, every care provider, every family. And that's hard work. In my city, it rains from October. The monsoon season starts in October and it goes all the way to next May, because we live in a rainforest. And I tell people, this is not something you do on a Friday afternoon between 1:30 and 2:30 because it's raining and you haven't anything better to do. You have to do it every day, every patient, every care provider. You won't get it right otherwise. And there's this truism that you have to recognize, that people in any organization are its most valuable assets. And we do tend to forget this, we tend to forget that those of you who are out there on the front line daily, you are the most valuable asset in the healthcare system. Why? Because either you make it work really well or you really screw it up. So we have to recognize that, and we have to put a lot of effort and a lot of time into thinking about, how do we make sure that those people who are the most valuable asset get the continuous lifelong learning about their positions, about their jobs, about their professions, which makes them that highly valued member of the organization. You can't just take a graduate out of a program and say, well, that's it, we're done. Have fun while you're out there. The organizations which take them on, whether they are acute care, tertiary, in the community, have a responsibility to say, now we have to keep educating you. Because if we don't, guess what? Adverse events. And something that I always feel I have to say is that the latest system is not going to make everything and everyone more efficient and more economical. And I don't know about you, but over the many, many years I've been associated with the healthcare system, I've seen them come and go, and come and go. Because people think, oh, this new system is going to make it work. Nope. You got to remember that it's people who make it work, not some kind of new system. And if you don't get buy-in from the people interprofessionally, you're not going to get a system that is improving. We have lots and lots of data on this. The fourth criteria is planning. Actually, this is a picture I took in a market by the river about 2 years ago. And I thought it was kind of neat. There's all those healthcare workers, all different colors and different shapes, wearing different clothes, etc. And they have occupational roles and responsibilities that have to be understood. You have to know what those people are doing. And you have to understand it not only across health, but also across the social care continuum, because when patients move out of the healthcare system, whatever that is, primary, tertiary, acute, whatever, they move into social care ultimately. So planning for that transition by understanding the roles and the responsibilities of that very amorphous group is hugely responsible, and again, an issue that has to be addressed when we think about interprofessional education. So, what is an effective team member? Now, this is not an exhaustive list, but I don't want the list to go on and on forever and ever because it'll sound as though I'm going to perform a miracle. But what we know is, from some wonderful work done by Michael West in the United Kingdom a number of years ago, and some more work that's been done in the United States, that when he or she, the team member, is interested in and cares about other people. Now watch that, is interested in and cares about. Interested in and cares about others. They align almost 100% with team goals. When they're interested in and they care about, they listen to others. They value their contribution because they're interested in and they care about others. They become inclusive. It's not, oh, them and us. And I won't tell you about the classic battles because you know what they are, power, etc. They accept and respect diversity. And in any healthcare team, there will be diversity. There will be diversity based on the culture of the profession in the team, the age of the team members, and what their profession is. If you are interested in and care about others, you will accept that diversity and work with it. A very, very, very important interprofessional quality. They become willing to share ideas and materials, and one of the major problems that I'm sure many of you know about in eMERGE emergency departments. No, let me take the OR. In the OR was the unwillingness of nurses to share the ideas that they had and maybe the materials they were working with the surgeon. Checklists are getting us past that, but what made that such a very high-level criteria for effective team members was taken from the airline industry, where it was recognized that the pilots who came out of the Second World War, because most of the guys, and they were guys, flying airplanes in the 40s, the 50s, the 60s, the 70s, and the 80s had been in the forces, was what we called their jock approach to piloting. I'm the chief. Don't tell me that the right engine just fell off. That's none of your business. So when the airline industry said, we've got to begin to share some ideas about what's happening in the back of the plane, things changed. And we have to change too. We have to be able, as good team members, to share ideas and to say, you realize we've left the sponge inside that poor patient? How often does that happen? More often than we know. Okay. And one that's really critical is to recognize and credit other people in the team for doing a good job. Right? Saying, you know, that was really neat what you did today. That was a very nice thing to say to Miss whatever or Doctor whatever. Very simple human little interactions. And then finally, when you have somebody who is interested in and cares about others, they are prepared to address conflict openly. And you think of the times when conflict is hidden because nobody wants to really talk about it. But when you have a really good team, a high-functioning team where people care, are interested, that conflict comes up and you talk about it. And you talk about it assertively and say, this cannot go on because who's suffering? The patient. So, effective teamwork when there's a clear purpose, a shared vision, when there's good communication, and we could say a lot about that. We began to talk about communication yesterday. I could hear it going on. Lots of different ideas about communication. And I'm a former linguist, and believe me, I think a lot about language. Effective coordination, critical, and then active participation of all members. Effective teamwork is when there's all those things, and in addition, when the administration supports with protocols and procedures and builds effective mechanisms to resolve conflicts that occur, then you begin to see effective teamwork. Over the last, I would say, 15 years in Canada and in the United States, I don't know about Thailand, and you can tell me, there's been a very, very big move to listen to the patient's voice, right? We're all patients in this room. I'm a patient, you're a patient, you're all patients, okay? So there's been an understanding that the patient has to be that individual who we consult about their care. We don't tell them about it, we consult with them about it. So the patient, we as patients, we need to learn how to participate as a member of a team. And interprofessional education, perfect for doing this, you know? Bring the patients in, and you start talking about what is it, and then you have a team of different kinds of health and human service professionals around, and the patient begins to be the center of the discussion. I gave a lecture once which was entitled, "The Patient is Not a Hockey Puck." You know ice hockey, right? You slap, and there's a little puck, and it gets slapped around the ice rink. The worst analogy for teamwork in healthcare is team-based sports, because team-based sports say, oh, we'll just chuck the patient from one person to the next person to the next person. No, the patient is not an object. The patient is a subject. And we, as we build those teams, have to teach them how to be active participants. Now I'm thinking of my mother, who died some 10 years ago now, she was 94, in good health. She would never ask her physician anything. I'd say, Mom, why don't you ask about, and she said, oh, no, he knows, because it was a he knows. Say, no, but you should know too, and you should tell him the things you've told me about taking a headache aspirin or something like that. No. That was a very cultural kind of idea in that generation until sometime in the 70s, 80s, patients began to say, no, wait a minute, I'm paying for this. And indeed, I might pay for it with my life. So let's make sure when you have to take an arm off, it's the right arm, not the left one, right? So, how to participate in the team. We can do that really well interprofessionally. And we have to show them, we have to show the patients, again interprofessionally, how to get information about their condition. Now, I'm going to state that I am a huge believer in pharmacists. Well, I'm a huge believer in every healthcare. But the pharmacist, because as one of my ministers of health once said to me, John, the pharmacist never tells a patient something bad. Did you ever recognize that? They never say anything bad. They say, here's the pills. Now, in my country, in Canada, pharmacists can now actually prescribe certain drugs, and they do all of the flu shots, and if you want other kinds of things, they do that as well. They are an amazing resource. And when I talk to elder groups about their health, I say, once you've been to the doc and the doc gives you a prescription, talk to the pharmacist before you take it. Be sure you understand. So we have to show patients interprofessionally how to get information about their condition. How do you get it, You shouldn't have to, it shouldn't have to be like asking for the moon just because you need to know what your x-ray results were. And then they need to know how each person on the team is going to contribute to their care. Okay? They need to know. They need the team member to say, I'm Miss X, I'm Mr. Y, I'm your social worker, I'll be working with your family and you to ensure that when you're discharged, et cetera, et cetera, et cetera. So each healthcare professional has to tell. And some are very good at this, but some of them are terrible because we don't teach them how to do it. We don't teach them how to do it well. I think one of the latest additions to our medical school curriculum was how to give bad news. We all know about that. Okay, so commitment, last criteria. Action items. So tomorrow, when you go home, think about this. And incidentally, you're welcome to this presentation. It's all open access. Plan and share. Plan and share values, goals, objectives. How are you going to build that into the interprofessional curriculum? All right? Define tasks, procedures, protocols clearly, and I think we said a little bit about that yesterday. Provide information on performance, good feedback on what was done right, and good feedback if something was done wrong. That is instructive feedback. Make sure it gets back into the system. It's not, you shouldn't have done that, it was, well, you did that, but let's think about why you did it, and let's think about what would have been the more appropriate behavior to do. And then cooperate so that the team learns to review and reflect on the progress they're making. And we could do a whole heap of stuff around who's the team in terms of its organization and how should a team meeting be organized. That's really critical. And then there are the behavioral items like mutual respect and trust. You have to have a team that demonstrates that. We have this in the competencies, all right? Communication, regularly and honestly. I'm always surprised at how irregular communication is amongst team members within the healthcare setting. And even if it is quasi-regularly, it's not always honest communication. People will frequently tell you something you want to hear, not something that they actually know is right. We have to be careful of this one. Understand and respect the complementary roles, and then, as I said earlier, handle conflict and emotions appropriately. If somebody is having a problem in the team, you have to be able to go aside and say, let's just talk about it. And talking about it, it's the greatest human thing we can do. Language is the best show that man and woman puts on, and we have to recognize that. Now, I don't want to talk about barriers too much because people get a bit depressed, but there's frequently a failure to appreciate the different roles that team members play. Well, you're a what? What do you do? Oh, you're a physio. I never knew what you did. Now tell me about it, okay? So this failure to understand what it is that one of the team members does leads to this depreciation of the value of that person in the team. Oh, they just do that. Instead of, this is what they do and it's really important. Power struggles that inhibit communication, that'll go on in a team. It's my patient. Well, actually, it's not your patient. Got to watch for this one. No. The power struggle inhibits communication because people say, I'm not going to tell you because I have my special code to talk about this patient. We call them acronyms, right? Acronyms. I'm going to write a book. It's going to be called Acronish, the Death of Healthcare, because every profession has a whole bunch of acronyms, which is a secret language to prevent anybody else know what it is you're doing. And then there's the attitude virus. Well, you know, we know about them. You're never going to get good interprofessional teamwork with that kind of attitude. And you have to be careful because power drives attitude. Frequent staff changes complicate staff learning. And when we talk about IPE, we have to talk about this really frankly, because when you work in acute, we know that the staff change from shift to shift to shift can be quite big. And we know that some of those staff changes will be not necessarily for the best of the team, which may be quasi-permanent. So it complicates the learning within the team because you bring in somebody new. Have to talk about this in professional education. And conflict and compromise, those things can be caused by the predominance of less experienced workers. They say, well, this is X and they haven't done it, so maybe we would not do it that way today. Instead of saying this is X, we'd better make sure that X does what X can do and the rest of us fill in whatever it is needs to be filled in. Otherwise, guess what? We have another adverse event. And then, as I said, poor communication, the curse of the acronyms. And almost finally, we have these personal and competing domains about which, at the present time, we know not very much in interprofessional teamwork and interprofessional education. Fear of change. We all fear change. It's a natural human attribute. But change is endemic to the healthcare system. Remember that our healthcare systems are really no more than 75 years old. And they keep changing all the time as we add more people with different sets of skills. In Canada, we have 65 health occupations in the bureau called Statistics Canada. In the United States, it's like 252. So imagine, you keep adding a new person and then things change and people say, well, that belongs to me and that belongs to you, etc. And that leads to this misunderstanding about other health professionals, or other professionals, not just health professionals. So personal misunderstanding. Differences in power, in income, in status. So let's just say, there's the medical model. There's the medical model. There's the medical model, and you say, wait a minute, this is not about models at all. This is about a patient. What we want is the best information we can get. Scientific method is actually a good thing, but I have to tell you that over the years I've become something of a convert. I was a terrible empiricist. I believed that if a number could not be put on it, as Lord Kelvin said, the great physicist, then it didn't exist. Only to be told, you know, John, if you do a qualitative analysis of interactions, you will find that a lot of stuff exists. So, income and status neatly conjoined because they are frequently associated with the medical model. Think about it. And we have to think about it really carefully when we think about interprofessional education. And then finally, language. Professional language and gendered language. As I said, all of the acronyms, the necessary professional language when we want to describe scopes, for example, but gender. In my country, 83% of the health social care workforce is female. About 22 years ago, a sociolinguist in the United States wrote an amazing book. The title of the book was You Just Don't Understand. Men Talking to Women. There is a difference in the language that women use. And we have hardly looked at it in the health domain. And it is a critically important piece of interprofessional education. Personal, these things, these competing domains, very, 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 very difficult to get our hands around, but we're trying. And then, of course, there are the institutional ones. Many institutions will have a different model of practice, so you move from one institution from another and you find the model of practice is not the same. That's a real competing domain. And then structures and priorities. You know, some have top-down structures, they have priorities about funding, they have priorities about building, etc. Very big competing domains. I just want to say very quickly that evaluation is incredibly important when we start talking about interprofessional education. We have to talk about what is it we're going to evaluate. So here I have a list of did the team member, etc. Participate, express, follow up, ask, carry out instructions. And did the leader of the team create the necessary structures, allow new ideas, etc., which is a revisit of something I said just a little earlier. And when you evaluate, you cannot be afraid of looking at the conflicts that occur, because conflicts do occur, and not all conflicts are bad. Some conflicts are necessary in order to cleanse the system of things that are going wrong. So did some members dominate? If you have a good team, you don't want two people who are talking all the time. Did some just withdraw and not voice their position? We have some wonderful data from shift change where we looked at 10 different health professionals in an acute, and strangely enough, there were some members who simply sat silent for the whole of the shift change summarization. Can't let that happen. You want to know, did the team reach agreement? Because conflict, when it's overcome, is agreement reached. Or did the team move too quickly to reach the agreement? That's another critical piece that we have to get into thinking about interprofessional education. So, the road ahead. It's not Friday afternoon between 1 and 3 and it's raining. Sustaining interprofessional teamwork and collaborative practice is a new way of thinking, and it involves cultural change. A new way of thinking. It's not, oh, we've got to put on another course. Nope. That's not a new way of thinking at all. That's an old way of thinking. Another course is easy. We just get the curriculum committee together and they figure it all out. So it has to be deeply rooted in learning and practice. And it'll require time, it'll require insight, and tenacity. Time, insight, tenacity. You gotta have that, because otherwise it'll just fade away. Let me just say one word about practice. Aristotle said something to the effect that if you want to know how to do it, You have to do it. And I am a great believer in taking interprofessional education for collaborative practice to the workplace, not the classroom, as I said earlier. So how do we think differently about what we kind of call practice education? You probably call it clinical education. We dropped clinical because the social workers didn't like it, which is fair enough. Anyway, so what is it that we have to put into those places? What's the learning we want the preceptors, the instructors to have, the skills they need to do inter-learning as opposed to disciplinary learning, okay? And it'll fail if you don't give sufficient thought to sustaining it beyond initial enthusiasm. The United States did a lot of this in the 80s, and I reviewed all of the stuff that they'd done. There was no thought given to how to sustain it past the original funding, which came from a number of foundations and some from government. You have to, as soon as you begin on this path, you've got to say, how are we going to keep it going once we've got it going? Very, very, very big issues associated. I've got a whole new conference on it. And let me tell you, it will not necessarily be solved by money. So I would go to places in Canada, they say, well, all we need is some more money. I'd say, no, you don't need more money. You need to think about the money you have and how you're going to use it differently to promote interprofessional education for collaborative patient-centered practice. You give people more money and they'll just spend it flippantly, in my view. They've got to think about what they have and then how they use it in a different way to promote interprofessional education for collaborative, because that's sustaining. The budget is the budget. Reforming the culture is the golden rule. Remember, in the healthcare environment, we have the most highly educated workforce in the world. The most highly educated work. Just think of the degrees, the diplomas, the certificates, the this and the that, which everybody has in healthcare. Highly, highly educated. And the lesson that we have to learn is that regardless of that, when we're there working on a problem that is about a human being who is the patient, you have to treat others as you would like them to treat you. The golden rule, thousands of years old, and we forget it. And we forget it at our peril. There is no place for professional exceptionalism in interprofessional teamwork. This is pretty good teamwork. Thank you for your attention, all my relations.
Thank you so very much for a very impressive presentation. And ไม่ทราบว่าทางฟอร์มีคำถามไหมคะสำหรับดร.กิลเบิร์กให้ได้สัก2 คำถามนะคะ มีคำถามไหมคะ Raise your hand up อาจารย์หมอวณิชานะคะชื่อไม่ได้เชิญ
Thank you, John, for your very fantastic speech and information on IPE. As we are very new in Thailand, we are very new for IPE, and I'm quite sure our participants in this room, either dean, deputy dean, or director, or executive members in their faculty members and their faculty or institutes. Could you please give us three key roles or key suggestions on how to motivate our faculty members to move on IPE in our institutes?
Yes, you can.
So you know that Harry Potter had a magic wand, right? Zap! Go for it! I don't know, I mean, you have to understand first. You know, if you don't understand, you can't move anywhere. So go read some really good stuff about interprofessional education. And there's some really good stuff now. Read, get informed, because without that information, you can't go anywhere. All right? So that's the first thing. Secondly, bring together a very small group, 7, no more, no less, of people who have expressed an interest in this particular area. Get yourself a cup of coffee and a sandwich or whatever it is you want, sit around a table for 2 hours and set yourself a little agenda. This is what we would like to do. This is why we would like to do it. This is where we're going to do it. And this is when we're going to do it. Just a little group of people. You have then your first pilot project, right? You just say, let's go to the diabetes clinic and give this a whirl. All right, let's figure out. So that's the second thing. Go read, get a little group together. And then thirdly, think about how to be a revolutionary. You know, how do you, and your small group should talk about this, how do you understand what it is you've read, understand the project that you have, and can now take it to the levels of administration within your institution to say, do you think we could actually try this, see how it works? Don't give them any big push, you know, you're not saying give me $1 million baht or whatever. It's just, can we give it a try? Because those little steps take you to a bigger step. And the bigger step takes you to an even bigger step. And in the end, I think that if I was in Thailand, I would be trying to develop a network across your excellent universities and colleges of people, like-minded people, so that you can actually explore the clinical and other possibilities within remote and rural regions where you can actually do this as well. But take those 3 simple steps first, and then the big ones will start. Easy. Harry Potter. Yes. There's a microphone right there.
เพนซิรินะคะนครพนม Nursing College ค่ะ Thank you for the wonderful presentation. Anyway, I wonder if you could give us some example of the situations in which you don't have an effective teamwork member, particularly related with difference of power.
Yeah, okay, good one.
When collaborate.
Yes, okay.
And how do you
change it?
Yes, thank you.
Okay, it's not an impossible question. So I have a very, very good friend who's a pediatric neurosurgeon at the Children's Hospital in Vancouver. And he is very interested in safety and is in fact now chair of the board that I sit on in British Columbia. In fact, I also sat on the patient quality review boards, which is another story. Now, I was very interested in a specific part of safety, and I decided to go to see him because I knew he'd been doing some very interesting work in the OR. And so I went up and I said, Doug, you know, I hear you got this really interesting checklist you've been developing. Do you think you could share it with me? He said, sure. And he's a very, very open and mature, and I use that in a guided sense, very mature surgeon. So I said, well, how's it going? How's the checklist going? And he said, well, we had a bit of a problem. Because when we brought the checklist in, it was me that had to check it. He said that wasn't the idea at all. The idea was that the team in the OR would do the checking. You know, they would check off each of them. And I said, well, what was the thing that really got you kind of upset and puzzled by the checklist and what you were trying to do? He said, well, you know, we had a baby in, and I think the baby was very, very small, 500 grams, tiny, you know, preemie baby. And we were standing around before the op, and I had started a protocol which said, in the OR, everybody has to introduce the person on their left-hand side, say their name, what their professional background is, what they're going to be doing during the operation, and what they'll do when it ends. And he said, when we first started this, it was incredibly awkward. The team would not really, they'd mumble, and he'd say, come on, you've got to talk about yourself, you know? This is important. We have a baby here we're going to be operating on. He said the real eye-opener was when they just done the round, and they were just about getting ready to do the surgery. And the nurse finally put up her hand and said, do you know what? We don't have the weight. And the anesthetist went, what? He said that was the real eye-opener for him about having to change the culture in the OR, that it still hadn't sunk in. So then they began training sessions for the pediatric OR at Children's Hospital. And as I was leaving the office, because this was very interesting information for me, because I actually had seen the checklist at the Apollo Center in Florida, you know, the original checklist when they were saying, yeah, is the booster on, is the whatever. I said, well, how's it going down in Canada? He said, I hate to tell you this, but we only get 40% compliance from the surgeons. 40%. Now, it's probably about 65% now, but compliance rates are still pretty low. I don't know what they're like here. Compliance rates with checklists are still pretty low. Why? Because the surgeon said, well, we're the one in charge. And Doug said, but you know what? The airline industry finally told the captain, you're not necessarily the one in charge. So there's a very, very interesting heap of things around that issue. Thank you for the question. It's very tough. Yeah. I don't know anything about obstetrics and gynecology, remember that.
Okay. พิเศษลุงพิการนนท์ from ขอนแก่น University. Again, thank you very much, John, for your very interesting and very easy to understand talk. What you have been telling us, I consider is it from the origin of the liver. That is from the educational side. Can we do something, and should we do something from the end of the liver? That is the workplace right now.
Oh, yeah. Yeah, that's a huge issue now. I understood that yesterday morning we were going to have the Minister of Health and the Minister of Advanced Education. Very interesting problem, this, because in my country, the two don't talk to each other. Oh, funny, huh? Yeah, right. Goes on all over the world. So the problem, I'll give you our problem, is, and it's probably somewhat similar here. So in my country, well, and then in my province, but it amounts for the whole country, the Ministry of Advanced Education, which deals with the universities, colleges, and institutes, decides how much money they will get per student in that institution. So if it's the French department, they get, you know, $12,000. If it's the Faculty of Medicine, for each student, they get $140,000. Go figure. So the Ministry of Education has very little cross-chat with the Ministry of Health, because the Ministry of Health says, well, we need more of X's, we need more Y's, we need more Z's, and we say, no. Population health says that's not the way to do the calculation, but that's another story. So the issue then becomes when, let's just take an example. When the dollar, just $1 of the whatever $20,000 going into nursing is going into nursing, when that $1 goes into nursing, how much of that $1 that goes into the particular program, let's not name any, the dollar that goes into the health program, how much of that $1 should actually go to the community for all of the education they do? And guess what? It's almost zip. And that's a huge error in the system. And that's why we have to get education and health together to say, when the dollar comes into the post-secondary institution, it has to be marked so that at least 30% goes back out into practice so that we can educate those people who are practicing. We can tell them, you know, we have skills that we can teach you, we have metrics for evaluation, we have ways of doing, you know, et cetera, et cetera, et cetera. And I, as you know, I'm a huge proponent of doing interprofessional education in practice. But until we can sort out the dollar, you can't blame practice settings for saying, we can't afford to do that. You say, although I have an answer to that one, believe me. And it's legitimate, you know. So if we can figure out the costing for that piece and make sure that the practice setting gets that money and spends it appropriately, then you will see huge change. But at the moment, I'm afraid we're a long way from that. But out there, where the real problems are, as I've said, that's where the students really get it. You know, they kind of say, oh, I didn't know that a social worker actually did that, you know, maybe however many years and whatever. So it's a very, very difficult problem. But I have a suspicion that it's a universal problem in advanced healthcare countries. This lack of passage of dollars across the border into practice where it's clearly needed. Because I think it's unfair to ask practice settings to do all this on the budgets that they have, because the individuals have to be released from care time, right? And you can't just say, well, take 10 fewer patients. No, that's throughput. We need that money. So, not an entirely satisfactory answer, but I understand the frustration because I have it in spades. Yes, you have a question.
Thank you, Professor John, for your excellent and inspiring presentation. I have a question about do you have any special model for networking for let me say like a private school who also would like to have this kind of model, interprofessional education, but they stand alone. They don't have other faculty and other profession, but they would like to have this kind of education.
Yeah.
Do you have any special model for them, like what kind of networking that they can work with?
That's a really, again, there are no poor questions. Every time I hear a question, I say, oh, that's a great question. But believe me, there are no bad questions. There are always great questions. So there is, in my country, we are doing a huge study of early learning, all right? Children's early learning, because we are well aware that education is of incredible importance to the life of the individual. If children do not get educated at the right time, with the right kinds of materials, their social progress is extremely slow, if not there at all. So what we've been doing is looking, we have a big research project that's going on out of my university, looking at children who live in deprived communities in British Columbia, and trying to understand how we interact with the teachers actually we start in kindergarten and some in daycares because we have some daycare coverage, trying to understand how those children who come from poor homes can benefit from the kind of care we should be given. So just take teeth as an example. You know, teeth is a really big problem for little children. So, you know, providing dental care, very, very important. But I have to say that we haven't thought through that linkage with the primary education sector as well as we could, simply because the training of teachers is not like the training of most healthcare professionals, and we just don't understand it as well as we should. That's not an excuse, it's just an observation that it's another place we have to go. But it's a great, we know it's really, really important. And determinants, social determinants, that's one of the educations, one of the big social determinants, like clean air, clean water, education, literacy, etc. Yeah, thank you. We're done.
And thank you so much for your answer. And please give a big hand for him again. Thank you. Next.
And in this occasion, I would like to invite Professor Dr. Kun Ying Korpjit Limpa Phayom to present a token of appreciation to Professor Dr. John Gilbert.
We'll have 4 E's here. We've got 2 people.